Bun-da-da-da! All right, guys, we are doing the tests, the lung cancer test, the TB test, as well as the PE test. And the PE doesn't stand for physical education. It stands for pulmonary embolism. Now, you, the contestant here, have the opportunity to answer these test questions correct and fill in the boxes. So I want you guys to get out a blank sheet of paper, blank sheet, make a table just like this, and try to, from memory, just try to fill in as much as you can, okay? So go ahead and pause this video. Okay, now you can unpause me. But go ahead and pause this video, and we're gonna fill in the boxes as much as you can to your memory, and then in this next little segment, I'm gonna fully disclose everything that's in the boxes, okay? So go ahead and pause your video and try to do your best here. So if you did not pause the video and you did not fill in the stuff behind me, you guys are cheating. Go ahead and pause it before I come into this camera screen and strangle you. Whoa, Mike, things just got serious. All right, so let's go into our signs and symptoms and how they're different in lung cancer, tuberculosis, and pulmonary embolism, all respiratory complications. Now, your patient will come into the ER presenting of almost the same types of signs and symptoms. So we're gonna do a test that kind of rules out what your patient has. And once we do the test and kind of figure out, well, the doctor does this, the doctor diagnoses the patient, then we'll talk about some RN management for each case. So let's go over it here. So for lung cancer, let me scoot you guys over. For lung cancer, your signs and symptoms, you have a voice that is hoarse, or like a very raspy voice that's hoarse. Usually in lung cancer, you have some type of tumor. And most of the times, lung cancer inside the lungs doesn't stay where it's supposed to. It climbs up the respiratory tract, gets in the vocal cords, goes up the larynx, can't even be involved in the pharynx, and sometimes you have to do a bunch of surgeries. So, one of the first things is a voice that is coarse or hoarse. Then you have a cough. And obviously, you know, everyone has a cough in most of these diagnoses. All the respiratory diagnoses usually has a cough. But one of the big ones is you have very bloody sputum. That's one of the big ones. Shortness of breath is a complication for a lot of respiratory complications here. You have weight loss, the same as you see in tuberculosis. You also have fatigue and something called effusion when your lung starts filling up with pus. Sometimes you'll have to go in there, stick it with the needle, and drain it, okay? So next is your TB. Now for TB, you do have a cough. Yes, that's true. But it's a different kind of cough. You don't have a very bloody cough, a very thick sputum cough. You have what's called a blood-tinged sputum. So instead of your patient blasting out a lot of blood, like the guy from Breaking Bad, he had lung cancer, that chemistry teacher. If you guys have never seen that show, then I'm sorry. But you're missing out. No, I'm just kidding. Blood-tinged is like spots of blood, okay? Actually, bloody sputum is like big bloody sputum. You're gonna have a dry, your patient's gonna be dry, very purulent type of drainage. You're also gonna have anorexia as well as weight loss. Now, some of these things can co-mingle, but the biggest thing with this one is your blood-tinged as well as night sweats. Because remember, tuberculosis is a bacteria. Your patient is infected. So night sweats is a big complication for tuberculosis. PE, pulmonary embolism, you're just talking about a blood clot inside the lungs. Lung cancer, you're just talking about a tumor inside the lungs, okay? So with PE, let's get into that one. you have increased respiratory rate, you have an increased heart rate, and you have an increased chest pain. Now, yes, you might have chest pain for lung cancer. Yes, you might have chest pain for TB. It's true. But the big one for PE is you have an actual blood clot, usually inside of the alveolar, or could be outside as well. But there's some type of occlusion that's preventing oxygen exchange at those capillaries, okay? So every time you take a deep breath, you're going to have chest pain. Your heart rate is trying to compensate, and your respiratory rate will be going faster. One of the other big ones that a lot of us fail to recognize is the heart anatomy and the lung anatomy and how they commingle. You see, the heart, let me erase some stuff here. The heart should be really drawn like this, like a broken heart. Whoops, just cut off my stuff here. And your lungs inside of the middle here, okay? Because what happens is your right side of the heart has deoxygenated blood that goes into the lungs to get all the oxygen exchange as well as hand off the CO2 to blow out all that carbon dioxide or carbon dioxide. But carbon dioxide is an acid, so if you guys want to remember it like that, that's perfect. Now, after the exchange of oxygen, we go back to the other side of the heart, the left side of the heart, and then that left side pumps blood throughout the entire body, okay? So what happens if we have a blockage inside the lungs? If we're saying, hey, you cannot go that way, you have to go around back the other way. Now we have some type of blockage in the lungs. Just like when your patient has fibrosis of the lungs or hardening, stiffening of the lungs. Your patient starts having a backup of fluid in this right side of the heart, causing cor pulmonale, or what's known as right-sided heart failure. So now we have all this blood backing up in the right side of the heart. Now what happens if it overflows the right side of the heart? Well, where did the blood come from? The blood came from the body. So now it starts to back up inside the body, causing your patient to have bounding pulses, as well as JVD. Now the very differing aspects of right-sided heart failure with your PE patients is you have a decrease in blood pressure, not an increase. And the decrease in blood pressure comes because you're not getting that perfusion to the left ventricle that pushes out that cardiac output and stroke volume and pushes out all that blood through the big mama of the left ventricle out to the rest of the body. So you could possibly have signs and symptoms of this right-sided backup of heart failure. So that's the big difference here, is you have increased heart rate, chest pain, that's a big difference. You could have chest pain with tuberculosis as well as lung cancer, but you will definitely, almost 100% of the time, have chest pain with your PE patients. Now let's get into our tests specifically. All right, so next is our tests here. So we're looking for, in lung cancer, we're looking for a spit culture test, or what's called a sputum test. We're also doing a chest x-ray and a CT to locate any type of masses or any type of tumors, okay? Another thing that we can do is a bronchoscopy. Broncho meaning the bronchioles of the respiratory tract, and scopy meaning video recorder, or basically camera that we're shoving down that throat and looking to see if we have any masses or tumors. We can also do a biopsy and take out what's called a sample of tissue and study it. Now, we try to do that with a spit culture, but it's best if we find a mass to biopsy and see if it is cancer or if it's benign, or what I like to call be nice, non-cancerous mass. So, with your bronchoscopy, that's just a diagnostic test that we do. Now, you guys are the nurses here. So what we're going to do is don't give your patients anything to eat. We're going to put them on NPO status before we start shoving things down their throat. Okay? So we're going to we're going to stop our patients from eating before the test. When their patients come back from the test, we want to make sure not to feed them until they get their gag reflex back. That is big for bronchostomy patients, okay? Next is your TB test. Guys, always go back to the pathophysiology here. So your TB test, we're gonna do sputum cultures. Sputum cultures. Get some of that lung butter, put it inside a cup, and we're gonna test to see what kind of bacteria, if it is TB, if it's not TB, maybe it's lung cancer. I don't know. Let's test it. Let's rule it out, okay? So sputum culture, all you need is one positive sputum culture to be declared positive TB. Then we'll put your patient under treatment. Now, big difference from, you need 3 negative, let me change that here. You need 3 negative sputum cultures to be discharged, to go back to work, and to be active in the community, like a normal citizen, okay? So you need a sputum culture times 1, we treat it, and then we do cultures to be DC'd here, okay? Next one is your PE. With your pulmonary embolism, go back to the patho. Is it bacteria? No. Is it a cancerous mass? No. Is it a popped lung? No. It's a pulmonary embolism. We have a blood clot in the flippin' lung. So what we're going to do is we're going to do a CAT scan. And that CAT scan, we're doing an X-ray of the body and seeing, hey, does this patient have a clot in the lungs? We're going to do a CT. If that's positive, what am I saying? If that CT shows positive, we're also going to put your patient under a heparin drip, but that's in RN management here, okay? We're also going to get the laboratory values of a D-dimer, as well as your PTT and your INR, which are your coagulating labs, coagulating factors, or coag labs. Basically, we want to know, is your patient having high clotting rates? Does your patient have a reason to have a PE? Is your patient not on their anticoagulation therapy? Maybe your patient has a sedentary lifestyle, lots of smoking, very constricted alveoli, and has restrictive blood supply to the distal portions of the respiratory tract. All risk factors for getting a PE. So we're going to draw that D-dimer. We're going to draw those coagulating labs. And we're going to see, hey, does this patient have any reason to have a PE? Because if he doesn't, if this is normal, the CT is probably going to be negative. And it's like, hey, your patient has a PE. Well, the coagulating factors are great. The D-dimer is negative. There's no CT. So we probably just have something else. Okay? So let's go into RN management here. So RN management for your patients with lung cancer. So now we know your patient has lung cancer. There's a cancerous mass in the lung. What are we going to do? That little cancerous mass, we do not want it to spread. We're going to want to stop the growth of it. We're going to want to take it out. Surgery. Check it, cut it out. It's way different, guys, than your patient with TB. This isn't cancer. This is a bacteria that just sits in the lungs. Way different than PE. Physical education. No. Pulmonary embolism. That's just a clot in the lungs. So there's totally different routes of treatment. So you have to know the patho first. So for your lung cancer patients, we're going to tell them no smoking because smoking is a carcinogen. It makes it worse. That's probably the reason why they got lung cancer. Not 100% of the time, but usually. Sometimes patients who work with asbestos, and you guys see those commercials online. Like if you have asbestos, what's it called, exposure, you can be getting $1 million for your lawsuit. Big time in the 60s, we use asbestos for everything. You can have a heavy metal exposure for your patients who have done heavy metal. Alright guys, not that kind of heavy metal. The heavy metal we're talking about is something that's inhaled from those steel workers or PVC lining type of work. We get fibrotic lungs, we can inhale carcinogens, and get toxic lungs that could lead to cancer. So the first line of treatment, what we're going to do is we do not want to do surgery as the first line of treatment. Okay, that's always the last line. We usually go most invasive first, or basically least invasive. Basically the most mildest route first. So the most mildest route is chemotherapy drugs. And if you guys want the entire lecture on chemotherapy drugs, you can go to simplenursing.com, click the MedSearch tab, scroll down to the little cancer icon, and I got them there for you on the membership page. Chemo is horrible. It destroys your entire army. It destroys cancer. It destroys the good guys, the bad guys, everyone, the mailman, the milkman included, everyone's dying. So that one's hard on your immune system, and your patients can get sick all the time because there's no more white blood cells. Now, if that doesn't work, we're going to go for radiation. Usually we do them both at the same time, just depending on the staging of your lung cancer, okay? Depending on your staging. So, you're going to do radiation that shrinks the tumor. Chemo stops the tumor from growing, because chemo, what it does is it kills off all of the most fastest producing cells. So, cancer proliferates and recreates, and the mitosis of it, whatever you want to call it, it grows very rapidly. So chemo kills off the fastest replicating cells. That's why your patients lose their hair, alopecia, because the hair cells grow fast too. That's why your patients lose their white blood cells, because white blood cells are produced very rapidly. And your RBCs, they're produced very rapidly as well. So radiation shrinks the tumor from growing, okay? We're shrinking that tumor. And the last line is your surgery. And we're going to go in and cut it out. Okay? So that's the last line of surgery. We do not want to do surgery unless we have to. Next is your tuberculosis patients. Now, what is tuberculosis? Remember, TB is that bacteria that sits in the lungs. Not only the lungs, but it goes all over the body, in the blood, as well as the lymph. But it mainly affects the lungs. Now, is it spread by droplet precautions? Is it? That's a question for you. No. It's actually spread by airborne. And everyone's like, no way, and yes way. He didn't go there, he went there. Okay, airborne precautions. Why airborne? Well, for the longest time, I thought it was droplet because someone sneezes and there's bacteria in the drop and you inhale it. According to the CDC, the Center of Disease Control, it's spread through airborne. That's why we put your patient in negative pressure rooms. So we're taking all that negative air out. We're sucking it out like a vacuum. But the thing is that airborne droplets, some books say, and it's so confusing. So, if you guys want more information, I have an entire TB lecture for you. But the thing is that it's spread by airborne droplets, they call it. So if you sneeze into a tissue, put that tissue off to the side, someone grabs that tissue thinking it's trash, now they have tuberculosis all over their hands. So you want to tell your patients to drop that little tissue inside of the trash or put it like in a little plastic bag. Now, what do we tell your patients with TB? Well, we have 6 to 12 months worth of drug therapy. okay? All these drugs are very, very hard on the liver. 2 to 4 drugs your patients are usually prescribed. Now, I have all the TB drugs at simplenursing.com. If you guys go there, get in the membership site, and check them out. Now, we teach your patients to wear a mask for 2 to 3 weeks. Why do they want to wear a mask for 2 to 3 weeks? Why don't you tell your cancer patients to wear a mask for 2 to 3 weeks? Why don't you tell your PE patients to wear masks for 2 to 3 weeks? The bacteria, guys, it's always the pathophysiology. The bacteria and the route of transmission. We want your patient to be quarantined. Don't want the spread of TB in the community or around the family members living at home. So wearing the mask, usually an N95 mask, until we reach therapeutic levels with our drugs. And your patient will be on these drugs for 6 to 12 months at a time. Very, very harsh on the liver. So watch out for jaundice, as well as risk for easy bruising and easy bleeding, because we know that that liver helps your blood to coagulate, helps your blood to clot, okay? So if you don't have the coagulating factors that helps blood to clot and help you stop bleeding, you're just gonna bleed for days. So very harsh on the liver. Tuberculosis drugs, know them, own them, be them, okay? So last one is your PE, your pulmonary embolism. Now, why does your patient with a PE require anticoagulation therapy, heparin? Why do sometimes they require a clot buster? Why? We're not giving heparin to your TB patients, your tuberculosis patients. Why? Well, because it's not a clotting. It's not a clotting problem. It's a bacteria problem. PE, on the other hand, is a clotting problem. You have big clots in those little alveolar sacs. So we're going to get those clots moving again. But the thing is, we don't want the clot from growing, as well as we don't want your patient to be bleeding out because we gave them too much coagulating factors or anticoagulating factors too fast. So we're going to put your patient on an anticoagulator, IV heparin. Usually it's always intravenously. So your patient's going to be on a more critical floor. They're not going to be usually on a med-surg unit. They'll be on a telemetry unit, or they'll be on a heart unit, okay? So we're going to give your patients heparin, IV, intravenously. And then you're thinking, okay, well, why don't give them warfarin? Why not Coumadin? What the heck is Coumadin? I don't know. Okay, Coumadin is taken orally. It takes about 2 to 3 days to reach therapeutic range. We don't have time for 2 to 3 days. Ain't nobody got time for that. We need it right now. Like your patient is going into respiratory distress and going to lose function inside of their alveolar sacs inside the lungs. This is a critical situation here, okay? So we're going to bust out with the big guns. The heparin we give intravenously. Heparin is used to stabilize the clot. Now write that down. Stabilize the clot, okay? It is not given to bust that clot open and cause like a bunch of fragments everywhere. Heparin is used to stabilize clots, not just with PEs, with clots in the heart, on those big coronary arteries, the highways of the heart. It's also used in DVTs, deep vein thrombosis, usually clots all over the body. We want to stabilize it from growing. We don't want any more backup or traffic collisions. If you guys have seen the coronary, the heart, what am I talking about? the blood clots in the heart, or MI lectures. We just want to make sure that stabilizing and not growing the clot in the lungs. That's for heparin, okay? Now, if this clot isn't going away, we're going to use a clot buster, which is called TPA. And TPA is a very strong anticoagulant. It busts the clot wide open, and patient is very at risk for having risk for bleeding. They can even go into DIC. If you don't know what DIC is, I have an entire lecture on that as well at Simple Nursing. And this one is a big one. So monitoring your patient very closely on a higher level unit is required for that, okay? So hopefully this lecture has helped you guys with some critical thinking and determining the different signs and symptoms, treatment options, as well as tests for all of your, well, not all, but some of your respiratory complications. So know it, guys, own it, and we're gonna have a lot more videos just like this coming soon, because this one hopefully is good for you guys for learning and kind of prioritization and just like organizing stuff. I think that's what I was trying to display. That means organizing in your brain, okay? So if you guys want more lectures, go to Simple Nursing. If you already have a membership, go check out these specific lectures over there, and I will see you on the next video.